Can I have Dr. Ramesh Singh?
Thank you, Dr. Khanna. And,
Sorry for
Yeah,
the
so you're there, right?
minutes delay.
Okay, right. So now I can see you. So I would leave this to you for discussion. I think Dr. Sriram Narayanan is not here, and we will have the discussion so that we are not late for the next session. So you can start the proceedings. And
so Dr. Raj is not presenting, is it, Dr. Khanna?
Dr.
No, Dr. Rajnikant.
No, Dr. Rajnikant, I don't find him here. He was there in the previous session.
Okay, because his name is next.
Yeah.
Okay. Yeah. So we've actually had 3 very interesting talks, and maybe I'll just ask the first speaker, Dr. Rini. So I've never seen this condition before, actually. How common is it or how often do you see such cases? Number one. Number two, what is your choice or indicated anticoagulation, and what's the duration of your anticoagulation?
Okay. The cases about the Turner syndrome is the second case I have, but unfortunately, when I do something, when I open the left iliac veins, there is a perforation. That is my second case of Turner. But the anticoagulants, after the patients, I put the cover stents. The patient is under good conditions, and still I gave the patients with rivaroxaban for about 3 months, but because of the finance problems, he chose to go to the warfarin after 3 months.
So it's lifelong.
Yeah. Up to now, he's still with the anticoagulant.
Yeah.
For about less than years. This patient is about early on during the pandemic case. I did the cases during the pandemic. So this the patient, the second evaluation, when the first evaluation, I still a bit thrombus on the left femoral. So I gave the anticoagulant, but I changed to the warfarin. But for the second evaluation, the patient hasn't come back to my clinic.
Yeah. So I think anticoagulation is also a very important mainstay of treatment here, apart from your intervention, because this is recurrent. So that's one. And my last question actually will be directed to Dr. Wulan. While CTAP is actually evolving, from your experience, what is your success rate? How often do you have to take these patients back for repeat intervention?
Okay, thanks. So actually, it's not easy to have a diagnosis of CTAP, and the challenge in my hospital is we don't see them. Maybe this is the first. Oh no, it was the second case of CTAP, but this is with the apparent thrombus. But actually, there are so many type of CTAP which has in the distal branch of the pulmonary artery, and the shape of it's not the thrombus, the apparent thrombus, but rather it's like a web ring or a stenotic lesion of a very distal pulmonary branch, or some total occlusion, but in the very distal part of the branch of the pulmonary arteries, then you will not be able to see it even in the CT scan, unless you perform the VQ scan as before. So unfortunately, in our hospital, we don't have any VQ scan, but if you do have it, it will be very nice, because actually the incidence will be higher as what we expected, because once patient that you see any signs of pulmonary hypertension by echocardiography, and the age is like around middle age or 40 years old above, then you cannot find any other cause of pulmonary hypertension, then it might be one of the thing that we have to think, because in the chart of the diagnosis, once you have the PH sign in the echo, then VQ scan is one of the tools that we need to elucidate whether they have a mixed match perfusion defect. Then we will suspect a CTAP. And the next is, what was your question? Oh, the sequential intervention for CTAP. We cannot do it at once, because most of the time patients with previously suffered from DVT or post PEA with a residual pulmonary hypertension, then they will have a very small or quite a lot of area of the brains that may have some lesions. So once you do it all once together, then they will have a more complication than it shouldn't be there. So what we have to do is do it sequentially, like every 2 weeks or 4 weeks. Then some patient will need 3 to 5 times a series of the balloon pulmonary angioplasty.
Thank you. Thank you so much. I've got no more questions actually, Professor Khanna. We'd like to extend our thanks to the 3 speakers.
Okay, thank you so much, and thank you for being here. It means a lot that it's very late. I understand in your country it's pretty late,
Yes.
but all of you are here, and what gives me a lot of pleasure is all 3 of them have actually been trained by me, and they are doing so well in their country.
Very well.
So that gives me a real pleasure and
And this time, I want to thank you for Prof. Khanna, for accepted me as a fellow in your hospital.
All right. Thank you then. Good night.
Good night. Bye.
Bye. Selamat malam.
Selamat malam. Namaste.
Terima kasih. Bye-bye.
Bye. See you next time.
Okay, so now we thank you all very much.